Assalamualaikum warahmatullahi wabarakatuh, and a very good afternoon. First of all, I would like to thank the organizing committee for inviting me to be a speaker, but wanted to invite me to share my experience. I get a little bit jittery, when you're the last speaker. And everyone's so tired. You've had a good lunch, and you are, your brain is all saturated. Yeah. So, but I hope you will give me a chance, for the next 30 minutes to just perhaps refresh what you know a little bit about the eye. Yeah. Okay, I'll go first to the anatomy of the eye, just in case. Diabetes affects any part of the eye, but it causes blindness mainly when it affects the retina. Yeah. And this is the front part of the eye. The retina is the back part of the eye, and you see this is what we call the optic nerve, and that is part of the brain. So the optic nerve, the back part of the eye arises from the brain, and this is the only part of the brain that we can see. Yeah? That's why sometimes when someone has problems in the brain, they send the patients to us. Why this is important for you to remember is because when the retina gets diseased, it can never regenerate. So the patients will go blind, just like anything in the brain. Yeah? And this is the macula. 90% of what we see during the day or during light comes from this area. But it's not the same as in darkness. In darkness, we see mainly from the periphery. So when diabetes affects the eye, it affects the eye by having either diabetic retinopathy or diabetic maculopathy. Okay, I need you to understand before I go on. Okay, and you can see what happens when a patient has problems with diabetic retinopathy. All these are new vessels. I need you to see all these vessels as well, because I am going to show you mainly pictures. Yeah? So that you need to know what is normal before you can know what is abnormal. And over here you can see new vessels at the front part of the eye, what we call the iris. Yeah? So that is what we call reduced iris. And that patient has high pressure, and patient probably will go blind. Okay, one of the ways to detect diabetic retinopathy, the best way is to do screening through fundus camera, and this is what you see in a normal fundus photos. Okay. Again, this is the optic nerve. You remember that, which connects the eye to the brain. This is the macula, and these are all the vessels. You have the arteries, the veins. Yeah, arteries are smaller but thicker. Then you have the veins, and this is the retina, and this is the right eye. This is the left eye. Yeah, the macula is always on the temporal side. Okay. I am going to also show you scans of patients. We are very fortunate to have a scan called optical coherence tomograph. It is also part of laser, but this is for diagnostic purpose. Laser is not just for therapeutic, it's for diagnostic as well. So what it does is that, remember I mentioned about macula? It is so important, 90% of what we see. So we have a scan that focuses onto the macula to see whether it is alright or not. Remember the maculopathy? So I need you to remember also that this is what normal macula looks like in an OCT or a scan. Okay. Just a little bit about pathogenesis in diabetic retinopathy. We have microvascular occlusion and also leakage. I will not bore you, so I will go on. In microvascular occlusion, what happens is that when it's occluded, a vasoformative substance. I also need you to remember this word because I'll be talking from time to time about it. VEGF, vascular endothelial growth factor. I think you're aware of it, that is important in babies as well. As they grow, they must have VEGF. But what happens is that when there's retinal hypoxia, new vessels will grow. If you look at the heart, if there is any obstruction, the patients will go into acute myocardial infarction. But God has made it different in the eyes. When there's any obstruction, there will be formation of new vessels. But these vessels are not as strong as the original vessels. They serve the purpose of giving nutrients, oxygen to the retina, but they bleed very easily. And the next, when you have occlusion, when you have occlusion, that's what happens, new vascularization, new vessels formation, and subsequently, and you can see vessels here, can you see here? I showed you the normal fundus. These are all new vessels. It is there for a good purpose, macam baik hati ya, but it's also destructive to the eye. Okay, so this is bleeding, and subsequently the patients will develop scarring. Okay. So the next pathogenesis is microvascular leakage, and what happens is that they will have macular edema, and you can see, remember the normal scan just now, you can see fluid here, and also when there is leakage, what comes out are water, lipid, and protein. So you see this accumulation of debris, and it's swollen, and this is, can you see how bad it has gone? It's like a hill. The patient's vision is affected. So what I'm going to talk about today, focus is on 9 pregnant ladies who presented to us from July up to September. So 3 months we had 9 pregnant ladies with bad eye problems. You've seen thousands of pregnant ladies in 3 months. But these are the ones who were referred to us with very, very bad eye problems. So they range from 23 to 42 years of age, and out of this 9, 4 underwent termination of pregnancy, and 1 had a missed abortion at 16 weeks. Spontaneous abortion. So this is a very busy slide, but I am just going to focus, these are all the 9 patients that I mentioned. I'm going to focus on those who underwent termination of pregnancy. Patient number 1, yes, okay, she had termination of pregnancy at 16 weeks, and I will not be able to show you her photos because she came with hemorrhage in one eye, in the better eye. The right side, she was on our follow-up because of rubiotic glaucoma. She has glaucoma due to new vessels. You remember on the iris? That kind of vessels but at the angle. So the pressure built up, and that caused her to lose that eye. She had one good eye, but she was not prepared for pregnancy. She became pregnant and her vision dropped. So, and number 2 is the patient with spontaneous abortion. Number 3 is a 27-year-old lady, G2P1, at 20 weeks. Yeah, and she opted. I have, felt like, I hope that she would continue, but she opted because this again was an unplanned pregnancy, and the vision dropped in the right eye from 6:36 to hand movement. I just would like to inform you, prior to that, she was on follow-up and her vision was poor, not very good. She had low vision. 6:36 means that a normal person can see an alphabet, say for instance alphabet H, from 36 meters, but she could see the alphabet from 6 meters. So, and in the other eye, she was seeing 6:18, it dropped to 6:16. So here's a lady who's seeing hand movement, one side 6:60, one side she could not see. She was 20 weeks pregnant, so she decided to go. And we were giving her treatment prior to the pregnancy. She stopped the treatment when she was pregnant. Okay, so the third was a 37-year-old lady, TOP at 14 weeks. The last childbirth was 20 years ago, unplanned pregnancy. They are poor, they are rubber tappers. She was not keen on pregnancy, and her vision was 6:9. It dropped to 6:16 hand movement, so she opted for that. She readily said yes. So the fourth was is a 37-year-old lady, but she's gravid at 7 para 5. So at 12 weeks, she already has BKA, she has severe anemia, and after some counseling, the husband consented to her TOP. I would like to also to focus on this lady. She's 32 years old, G3P1 plus 1, So she had treatment done for PDR, proliferative diabetic retinopathy, in 2014. By 2016, she was stable. The eyes were stable. When she came back, everything looked alright. There was not much worsening. Therefore, we just opted to wait and see. I need you to remember this, because just in case you think that all ladies need to go for termination of pregnancy, that is not true. If they are ready before they are pregnant, then the pregnancy will not cause them to be blind. Okay, just relax. All the gross photos, So remember the normal photos? This is one of them, 37 years old, the one with spontaneous abortion. I'll be showing you the video later. She has got blood covering the macula, and she could not see. The left eye, she had trauma as a child, so she was practically blind at that time. Second patient, age 23. When she came, this is bleeding, hemorrhage in the eye. Look at how bad it is. This is the right, this is the left. She has delivered, and she is scheduled for surgery on the 30th of this month. This is a 34-year-old lady. And if you look at this, all this neovascularization, new vessels are abnormal, but she has had delivery done via LSAS. This is actually the same lady, but I can't take photo of this. You cannot see that there's edema, but there's edema here at the macula, but it's not as bad as the one that I showed you earlier. Okay, next patient. Look at all this. Fibrosis. This is all scar tissue. right eye, left eye, and there's a little bit of edema over here, and you can see the scar tissue over here, pulling onto part of the retina. She's 37, right eye hand movement, left eye 624. Pinhole 680. Left eye is okay. She's scheduled for surgery in November. 37-year-old lady, poor compliance, vision drop from 6 to 6, and I told you, 6 done, she had TOP done. Okay. So I actually called her on Friday, and she said, I still owe the hospital money, I'm not keen to come. But I still say, okay, I hope you will come. An appointment has been given, because she could go blind. But I would also like you to see that these photos that you have taken was on the 27th of August. We gave her, remember I was telling you anti-VEGF? We gave her VEGF, so we gave her anti-VEGF injection straight into the eye, into the vitreous cavity. And she had termination of pregnancy on 6/9 at 14 weeks. I do not have, we don't have a fundus camera, so we are borrowing the MOPD. Fortunately, they're very kind. So if you can see over here from where you sit, there's less blood over here. There's still scar tissue and pulling, but there's definitely less blood. And over here, definitely less blood, but there is swelling. So it might be due to the termination of pregnancy combined together with the anti-VEGF. Yeah? So this is a lady with very bad macular edema. Yeah? The right, and this is the left. And at that time, she was 12 weeks. This is the one with the PKA, severe anemia. If this goes on, what happens is that it could become worse, and she will be left with macular hole. This will rupture and cause macular hole, and that will necessitate surgery. This is the lady that I told you that she was well prepared prior to surgery. But she also has this macular scar that's also from diabetes. Yeah, so she has a good eye in the right, not so good eye in the left. Okay, so this is a scarring that you can see. The other eye is alright. So what is our treatment? 1, gold standard laser. Number 2, anti-VEGF. So what is anti-VEGF? First of all, if you remember VEGF, it exerts multiple functions here, including vasculogenesis, neuroangiogenesis, and vascular permeability. And its usage in pregnancy has been associated with spontaneous abortion, preeclampsia, but it has been documented that the use in third trimester is usually safe. So what we do is that the injection goes straight into the vitreous, because if it cannot go anywhere else, because the eye has good protective mechanism barrier, what we call as blood retinal barrier. So it will not enter the eye easily. And the last is surgery. So this is what I do, and this is a light, and this is a cutter, but before that we put in fluid into the eye, and at the moment we use either 23 gauge, 25 gauge is more expensive, so we keep it for children, and in the world they are also now producing 27 gauge vitrectomy. They're smaller and smaller, sutureless. Yeah. One surgery, just for the consumable, it will cost more than 2,000 for one surgery. No music, nothing. You might go to sleep, because this is what I do. If you go to my operating theatre, if the room is darkened, then you know that I'm operating. If we switch on the lights, that means that I finished my surgery. Yeah, so that's what you see, because So this is a patient whom you remember the light source, yeah, and also this cutter to remove blood. And initially you could not see very well because of hemorrhage in the arm. That made it darker. And I've put some triamcinolone or steroid over there, and that's what I do. Trying to remove, I remove the scar tissues. So one surgery takes about 1.5 to 2 hours. Yeah, it used to be 4 hours, but we have better machines now, and I'm doing more the past 14 years. And this is when I put in oil. Okay, case 2, number 2. That's what's outside, and we go in. That's blood removed, and you can see the scar tissue, a stump of scar tissue. Removing a bit of blood. I hope you're interested in knowing what I do. I don't have to do a lot of thinking. So this is removing a part of the which is dark, what we call the internal limiting membrane. Yeah, that covers the retina, the topmost area. Case 3, which I can see from here. Okay, you can see blood over here. Oh, this is a lady. This is a pregnant lady whom I did surgery. Spontaneous abortion. You can see that there's blood here. That's after I removed that the blood in the vitreous. Now this is blood covering the macula. That is the optic nerve. No, it covers everywhere else, it's okay, but it covers specifically the macula, so she couldn't see. So I was trying to add that. It comes in a piece, yeah? Fortunately. So you can see the macula over here. The most, the problem that I encounter is when there's active bleeding. The surgeons, like all of you will say, don't catch the RBCs, I have to catch the RBCs in there. The capillaries, and when they bleed from capillaries, and when they bleed, that can cause future scar tissue, membrane scar tissue. This is another patient. Just now, the white thing was a scar tissue. So that's removal of scar tissue and also blood. But it's not for all patients. These are for diabetics. I do other things as well for diabetics. Okay, I think that's enough. I'll just go on to the next. You can see. I don't know whether can you see the scar tissue, the white thing there? So this is to stop bleeding. That's cauterized. That's cauterization. Okay, I think I'll go on. Okay. The number of vitroretinal surgeons in government hospitals in Malaysia is very few. I'm covering Perlis and Kedah, and you have this in Penang, Perak. Perak has just received one about 1 month ago. Two in August, young one. Johor, young, and then this is all we have. I'm also going to Sarawak because there's no one over here. And these are surgeries that you cannot rush. You just have to be focused and do the surgeries. And challenge that I face as a vitroretinal surgeon, as on the 30th of September, and I've collected more this morning and this afternoon. 242 for diabetic vitrectomy alone itself is 113, and it's not inclusive of those who are inoperable, not keen for surgery, considering surgery. Waiting time at the moment is 8 months, but because I'm dealing with the retina and they can go blind. Say for instance someone comes in with a retinal tissue-based retinal detachment, I will push the rest to the back. So OTDs, Mondays and Tuesdays only. We don't have any more OTDs, but we work until night. So there are many things to discuss, examples and everything, but you can read that. But what I would like to points to ponder is that when a diabetic patient, a pregnant diabetic comes, should we consider termination of pregnancy? If you look in the literature, they will say that now we don't have to talk about TOP anymore. But in our setup, there are certain conditions whereby we still have to consider this, as you see in our visions. Okay, the use of anti-VEGF in pregnancy is also something that we need to discuss. When to deliver the baby, how to deliver the baby. If they are in that condition, they cannot be delivering the normal way. And when to go for surgical intervention, that is for the eye. I cannot do it during pregnancy. You know why? Because of the blood flow and everything. The rate of bleeding is going to be higher, and usually we need to wait after about 6 weeks. But can we wait 6 weeks? That's another thing. So my challenge is there's still lack of understanding regarding their problem, even though we will sit down, Dr. Bhuvanes and Dr. Baba, discuss with them. They still don't understand. I still get defaulters. And once they're non-pregnant, my doctors will put them in the general pool. After that, they are lost. So I'm glad that I've given this talk because I've collected them all and make sure that they come follow up and they will come in different pools. But I also wonder why we have so many patients in 3 months. So it must be Dr. Baba and Dr. Bhuvanes. But they have helped me so much, and we've had a lot of good discussions, and I'm really grateful, for the patient's sake. Dr. Rose and the whole team actually. So in summary, diabetic retinopathy is the commonest cause of blindness in working age group in Malaysia, and you know that the prevalence of diabetes is highest in Kedah, unfortunately. Pregnancy could lead to blindness in a matter of a few months. TOP needs to be considered in patients with bad diabetic eyes in early pregnancy, and patients can still get pregnant if they have optimum eye treatment before planned pregnancy. And those diabetics in childbearing age need to be identified and properly counseled regarding the risk of blindness from diabetic retinopathy during pregnancy. And I think the effort should be taken to achieve, we all know, that effort should be taken to achieve a good metabolic control, preferably over a period of weeks or months before conception. But most of all, why I am keen to be here is that I would like to remind you that when a patient has diabetes, all of them need to have their eyes screened and at regular intervals, because I'm just afraid that sometimes when they have had their eye screen once and it's okay, done. It is not for the data. It is for the visions. Being blind is difficult. It is really difficult. Yeah? So I really need all your help, in order to help us decrease blindness from diabetic retinopathy. Okay, thank you very much.